Hello everyone, and welcome to the 4th Healthcare from Home webinar. Oops, sorry, I can't move. Here we are, webinar 4. My name is Lynn Laidlaw, and I'm a patient and public contributor to research, and I'm a co-investigator on the Health Research from Home project. And I'm going to be hosting today's webinar with Coral Stevenson, who is the Administrative Officer for the project. And this is our agenda for today. And I'm delighted to point out that this webinar, the topic of this webinar was an idea from an attendee after webinar 1. And their suggestion was that we discuss the ethical dimensions to wearable data collection and digital inequalities. So we do listen to you. So first, what I'm going to do is go over the housekeeping slide for today, and then I'm going to pass over to the presenters. Oops. Sorry. Oh, sorry, housekeeping. Yep. So we are recording today's webinar, and the recording will be paused during our question and answer session. The recording will then be uploaded to our YouTube channel on Friday, and all those who registered for the webinar will be sent a link once that's done. So we really encourage you to submit questions in the question and answer box throughout the webinar. You can submit a question for the question and answer at any time. So everyone's mics have been muted for the presentation, and the host will unmute anyone who would like to ask a question live during the question and answer. And please feel free to use the chat box to interact with each other or ask the host for any technical support. So it's my privilege to hand over to Sabine and Mustafa. Sabine will be presenting on considering health equity when using technology for health data research collection. So over to you, Sabine.
Thanks very much, Lynn. It's a pleasure to be here today, together with my colleague Mustafa Ali, who will introduce himself in a minute. I'll start by sharing my slides. It's the first test, isn't it? Let me see if I can get that to work. Can you confirm that that's visible in full presentation mode? Yeah, very good. All right, yeah, so as Lynn already said, Mustafa and I will be talking today about how you consider health equity when you use digital technology to collect data for research. I will do the first part of the presentation and then hand over to Mustafa, who will share some learning that we had from applying some of the approaches and methods that I present, and what we learned from that in a particular project with ethnic minority groups in the UK.
Sabine, you're not in presentation mode. We can see the next slide. We can see that.
Oh, let me try that again. Is this better?
Yes.
Okay, thanks very much. Thanks, Will. So it's good that I already failed the first test. Now let me see if I can pass the second by moving to the next slide. Did that work?
Yes.
Good, good. So I will start with a short introduction on what digital health inequity means. So a bit of definitions, but also show you some characteristics of people that puts them at risk of experiencing digital health inequities. And then I'll talk a little bit more about potential approaches that you can use to consider health equity when you design a digital data collection tool. And like I said, I will then hand over to Mustafa to talk through some of the lessons that we learned by applying those approaches and strategies to a particular project. So, first part, introduction. What do we mean with digital health equity? So I think we should start with a definition of what health equity means. And this is a definition from the WHO, the World Health Organization. And it's about differences between groups, differences in health between groups. And I guess the key terms in this definition are that these differences are unfair, avoidable, and remediable. And often these groups, and we'll get to that in a minute, are often defined by socially, economically, demographically, and geographically characteristics. This picture on the left-hand side, I think, is a nice illustration what equity is compared to equality. So on the left-hand side, you see 3 people of different heights, and we give them all the same crate so that they can have a go at picking an apple from the tree. So this is equality. We give everybody the same help in order to try and achieve a certain outcome. The NHS is an example of a system that tries to give everybody equal access to services, for example. And there's nothing wrong with equality, but there are some problems with giving everybody the same, because you will see on the right-hand side, when you give people a crate that has the height that they need in order to reach the apple, you can actually make sure everybody benefits from that tree. So equity is much more about considering people's needs in order that they can benefit from a certain service and thereby can achieve a certain outcome. So I guess it's equity that we're focusing on in this presentation. When we then think about digital health equity, health equity is central to that definition, but it sort of highlights different aspects of digital health where equity issues arise. So it's in how we design digital health solutions. It's making sure that everybody has equitable access to those solutions, that everybody can actually use them and adopt them. And the last one is these equitable outcomes and having an equitable experience from using them. So again, in this presentation, we'll talk about how we ensure equity in all those different aspects of digital health tools to collect data for research can be considered when you develop such tools. When I'm thinking about who are at risk of experiencing health inequity, there's this really helpful list of characteristics. So you already saw it in the definition of the WHO that there are different types of characteristics that matter. And the Progress Plus is a useful acronym that gives you a helpful checklist of characteristics that often matter. You can see place of residence. So do you live, for example, rurally or in an urban area? Also, differences between countries are well known in terms of equity. Race, ethnicity, culture, language. Mustafa will talk a lot about that and what considerations that brings. Occupation. So we know, for example, from the COVID pandemic, that people who didn't have an office job and therefore couldn't do their job remotely were at much higher risk of attracting the disease, for example. Gender and sex. So in many situations, technologies, for example, may not be designed with women in mind. We know that, for example, for Fitbit-like technologies that are originally often designed for men, mostly. Religion, so it comes with certain beliefs. Again, that's something that comes up in Mustafa's presentation. Education and socioeconomic status. So what educational attainment have you got? And are you from maybe a socially deprived area? And social capital. So your environment, are you embedded in an supportive environment that may help you manage your health or use digital tech? This was the original list of characteristics, but I think later on they realized that often, there are other characteristics that also matter that might change over time. I don't think health equity or health inequity is a static thing. It changes for individuals depending on where they are in their lives or where they are in the world. Plus, the plus element of progress, therefore, suggests that personal characteristics associated with discrimination, not in that list, might be relevant. So age, I think, is one to consider. So, for example, older people, when we think about digital tools, are often thought of as being at risk of not taking those up or not being able to use these. Features of relationships, so your parents' background, what colleagues you meet or what friends you make in school, and then time-dependent relationships. So I think a key one in this list is leaving the hospital. So after being admitted to a hospital and being in a really supportive environment, you go home and have to manage everything yourself, putting you at risk of health inequity. So these are social determinants of health related to health inequity risk, but they're obviously nobody is just their age or not just their gender or just their religion. So it's important to always think of people having a combination of those characteristics, which we call intersectionality. And it's the intersection of those characteristics that define our risk of experiencing health inequity. And Mustafa will come back to that in his part of the presentation. So this is a useful addition when we think about social determinants of health, adding digital determinants of health, acknowledging that people's digital environment affects how likely they are to use and benefit from digital tools. And for reasons of time, I won't go through this in detail, but I think it's good to remember that there are certain things in people's digital environment that should be added to that Progress Plus list when you think about inequity. So now on to some approaches and strategies that Mustafa will then talk a bit more about in his part of the presentation. So for assessing potential equity impacts, I brought the Health Equity Impact Assessments Digital Health Supplements, quite a mouthful. Let's call it the HIRE. So the HIRE is originally developed in Canada to assess the impact of health policy and health programs. And it's a collaborative process that you do together with stakeholders to think through the equity impact of originally policies, but there's been a supplement that now makes this a good approach to think about the equity impact of digital tools. It's a 5-step process, and you can see those steps here on the right-hand side. In the presentation, we will mostly talk about the first 3 because we've got most experience with doing those first 3 steps. But you can see that it's about thinking not just about the negative impacts of digital technology, but also the positive impacts and how you can then manage those impacts going forward. And I guess that the purpose of doing a HIRE is to prompt service providers, but also tech developers to really consider health equity impacts throughout development, evaluation and refinement of digital tools. So just to give you a sense of what a HIRE might bring, I brought an example from our colleagues in Canada who did a HIRE for virtual care, so remote consultations with people from the north of Canada, so Indigenous Inuit people living in remote communities. And they identified this as a relevant population to think about because they have reduced access to the internet, but also there's a history of racism in the country, in health systems and policy more generally. You can see that what they came up with is that there's potential positive impacts of introducing virtual consultations because it might increase access to healthcare services and at the same time reduce people's travel time to see a doctor. So that's obviously a positive impact. But the negative impacts that came up by going through step 2 of the HIRE were that Inuit people may not consider a virtual consultation as safe and meaningful as an in-person consultation. And they might not want to access those services remotely. And you can see that there's also an opportunity in that step 2 to come up with some questions that the stakeholders in your group weren't able to answer that you can then come back to later. Then thinking about strategy, so that's step 3 of the HIRE. Obviously, you can talk to stakeholders about what they think might work, but there's quite a big literature on what works in terms of supporting digital health equity. This is a fairly recent review that came up with 3 sort of big types of strategies. So user-friendly designs, infrastructure, so that's more the technology, access to the internet, and then educational support, not just from professionals, but also from family members. And they gave sort of do's and don'ts in the facilitators and barriers that you see here at the bottom. I'm not going to talk about these clear groups. Clears is basically an alternative to Progress Plus. I'm not sure why they came up with their own, but that's what the clear letters refer to. What they also came up with is recommendations for how you make sure these strategies are actually working. So it's about co-designing those technologies with end users, collaborate with professionals to make sure you provide infrastructures and services, educational services that actually support people, raise awareness to make sure that the people who need support are aware where they can get it, but also make sure that the people who develop the tech and the strategies are aware of accessibility and other inclusivity standards. So I think this is a useful starting point for having a conversation with stakeholders about strategies. So quickly, a final thing, cultural adaptation is just a particular type of strategy to think about equity when you're working with groups with different cultural backgrounds. And that's what Mustafa is talking about, so I wanted to highlight that quickly. Cultural adaptation is basically a way to systematically think through what the cultural components are of your data collection tool. And then take those components and make sure that they're tailored to the populations that you have in mind without compromising the reliability and validity. This does include translation and validation of questionnaires in different language groups, but it goes beyond that. It's not just a cross-cultural validation of questionnaires. I think when thinking about cultural aspects, it's important to not just think about the things you can observe, like language or clothing, but also consider things that are more in the deep structures, for example, social norms or family values. My last slide just shows you the different layers of considerations for cultural adaptation. And I think the key thing for this presentation is to think about things that we can do in the content and design of the actual tool. So that's quite close to the actual tool. And what are the aspects of that tool that we can then adapt to make sure that the tool is culturally sensitive and appropriate. There's a reference here at the bottom if you want more information on this approach. I think it's a really useful paper to have a look at if you're thinking about cultural adaptation. I'm going to hand over to Mustafa for his part.
Thank you, Sabine. Thanks for having me here. So I'm going to talk about our experience working with ethnic minorities, particularly South Asians, and how, when we are developing a digital health tool, keeping in mind the health equity, so how development and use of that tool might impact people's health equity. So I'm going to share our experience with working with this community. So I will use the example of this tool, which is called Manchester Digital Pain Manikin. It is a digital pain self-reporting tool that a user can report its pain on the mannequin and indicate the location and intensity of that pain. And we have engaged with different groups to understand their requirement, that what would they expect to have in this tool, so that could enable them to self-report their pain. And if there are cultural considerations, so for example, if there are things that are interpreted in different culture differently, so how we might address it through core design approaches. So because we developed this tool as a tool that could assess pain over the longer period of time, so that it could capture pain fluctuation. So we wanted to make sure that it is easy enough for people to use over a longer period of time. And what we have learned in our feasibility study, where we wanted to see whether it is easy enough for people from different background or not, that among other groups, South Asians were the group who were less engaged with the technology. That means if, for example, this tool or these kind of tools are integrated in care pathways, they might face additional barriers. So that's what the group that we identified, and we wanted to understand more about this group. So like Sabine showed you the HRfH process. So this first step is scoping, when you will go to the literature and look what is available, recognizing that, okay, the literature might not give you the entire picture. So you might also consult with other community members, community leaders, or have informal or formal consultations or interactions with them. So, but what we found in the literature, that chronic pain is more prevalent in South Asians. Please remember that South Asians are a very big group with lots of cultural and ethnic diversity within. And then you will also read in the literature that prevalence is higher among older South Asians, and it is higher among women. So these are the groups identified in the literature. And when you see that how there are inequities associated with these groups, so it is seen that South Asians are less likely to receive initial treatment with MTX. And if we talk about delays in referring from GP to rheumatologist, it is 4 times higher among South Asians than white British people. And if you also look at journal literature, you will find that South Asians are among those groups who are less likely to use digital health technology in accessing care. And also in our research, we found that the pain mannequins which are currently available for pain self-reporting, they don't offer personalization and customization features that could enable or support people self-reporting of pain. So like I said before, so you, when you look at the literature, you will see that, okay, these groups are described, separately, and it sometimes feels that these are different people within the South Asian group. Just like, you were going through the list, like in Progress Plus, where there are different characteristics. But what we need to recognize here, that when we talk about a group or individuals within a community, it is actually, they come with different dimensions of their social identity. So they have the gender, age, their socioeconomic status. So you can imagine that South Asian women who are in their older age from the socioeconomically deprived background, who are the first generation immigrants, might have challenge in communicating in English, and they also have poor digital literacy. So they might be the one who might face the higher barrier than other South Asians. So just saying South Asian does not mean that everyone is included in that group. So we need to look at those characteristics which are more specific for. So basically looking at the intersection of these characteristics and identifying these subgroups within the South Asians. And for that, if you look at this graph, just to show that you can imagine that if there's a subgroup within this South Asian who might have several disadvantages, and because of that, they might have additional requirements that we need to consider. And this might be that group who is facing the highest disparity or inequities in the system. So this is the group that we need to work with. Next please, Sabine. And if, for example, we start working with these groups, so start addressing their specific requirements, let's say language barrier, and if we start addressing it through developing the resources in their own language, that does not mean that this will support, this will encourage them to participate or engage in developing these tools or evaluating these tools. What actually is important that we need to consider, that's trust. Next, please. So trust is that determinant which is recognized recently in most of the NHS vision documents, where they have said if we want to address ethnic inequities, we need to work on the trust, because that's what is missing. And for building that trust, we need to work with the trusted advocates within the community who might help us build that trust with that community. Next, please. So taking you back with what Sabine has shown you and applying it in the context of South Asian population. So we wanted to understand if this digital self-reporting tool is being used by this community, what kind of barrier they might face, and what kind of positive potential and negative impact they will have. So we identified different subgroups within the South Asian group. So one of the group was people with language barrier. Remember that not every South Asian would have language barrier. So here we are talking about that subgroup, which would have language barrier. Now, so what is how it is this tool? How this tool is going to support patient-provider communication, because if a patient who has a problem in communicating in English, then this tool can support, or the pain self-reports which are collected over the period of time, this can really enrich the communication between patient and provider, and it becomes easier for them to communicate about their pain. And if you talk about unintended negative impact, so what we learned that people don't have knowledge about certain pain terminologies. So when we interact with them, we learn that they don't know pain quality. What is pain quality? There are different pain quality descriptors like tingling, throbbing. So these are difficult. These would be very difficult for them to describe, because they have different expression in their own language, and sometimes they are not able to translate them into English. And this is even hard for those people who are able to speak English. Next, please. So when then we, after learning these positive and negative impact, we wanted to mitigate the effects of these negative potential, equity impacts. So we wanted to develop we wanted to develop strategies with them so that they could advise us what kind of things we need to consider when we are developing this tool, or when we are improve this tool further. So first thing that is important to consider, that's language. And I would say the most of the time that when we talk about language, the strategy comes to mind is translating that English into Urdu. But we also need to recognize that not everyone would be able to read Urdu. So for that, you can use alternate formats. So for example, you can use audio, and you can embed that audio within the digital tool, and you can listen to it so that you can answer that question properly. A second factor is content. Like I was saying before, pain quality descriptors, they are not easy to describe in English. And even if you try to describe it in their local language, so there are very different expressions for that. So the purpose was to harmonize those terminologies so that, whenever we're talking about something, everyone would make sense from it uniformly. So what we did, we co-designed pictograms with them. So for example, if you look at this, it tells you that this is a throbbing pain. So by looking at the pictograms, you might not have to think about how to describe it. You can describe your pain quality by just looking at the pictogram and selecting it. Next slide, please. And the last important bit is context. I would say the context is the most important bit, because if you want to engage with, or if you want participation from the community, and if you are thinking about that group which is facing which is at the highest risk of the inequities, you need to think about the context in which they would be comfortable. So for example, if we are talking about their participation in research, so that they could tell us that how this tool should be developed further, then we need to think about the context. So how we are inviting them into the study, what resources we are using, and for that, what we have learned. Next slide, please. That we need to think more about inclusive research. We have been doing some work on this, like in terms of having translated version. But I think so, like I said before, if we are not addressing the issue of trust, then other efforts might not be as useful as we are thinking at the moment. So for example, involving these trusted advocates, we have worked with imams from the mosque, we have worked with other charitable organizations. So what's the benefit of working with them is that they already have trust relationship with the community. And if we leverage that trust relationship, we might not need to develop it. It does not mean that we should not focus on developing our trust relationship with them. It is just like it is a facilitator in developing that trust relationship between the community and institute like us, or researchers like us. And again, thinking about that how this community lives together, we need to think about the factors which Sabine was referring to as structural factor, where you would look at the family values. So for example, there are certain gender norms where they provide support to each other. So for example, parents get support from kids if they want to get they want to learn new digital technologies. Generally, kids would provide that support. And there's a cohesion within the community. There's some sort of interdependence within the community which they value a lot. So why not to capitalize on these resources and strengths within these groups, and use it for use them as a facilitation for them to get involved in, work with them on developing and evaluating these tools. So, for example, if there's a uh, uh, if there's an issue of ownership of devices, then perhaps they can share their devices to support each other. The digital literacy, for example, if you combine if you have a group with young South Asians with older South Asians, then they can support each other. And those older adults can learn those digital skills which older adults are lacking. And health literacy. So these are these are the things which, if you look at them as a community and see what resources they already have, we can we can capitalize on those resources and can use them for our benefit as well as for their benefit. And for that, one last thing before I hand it over back to Sabine. If we want to develop these tools for the benefit of the community, we need to think about all these engagements and in long term, and that's only possible through by developing partnerships. So these community organizations, these are the excellent resource within the community whom we consider as important partners, and we can empower them. We can build their capacity so that they can deliver part of the research within the community, and then we can work in partnership so that in going forward in digital health research, their participation is increasing, which will help us understand their requirements and translate those requirements into developing these technologies. Thanks. This is all from my side. I will hand it back to Sabine.
This is just a summary of what we've been talking about. So it should all sound familiar. So digital health and equity, topic of the seminar is about unfair and avoidable differences. And I think as a research community, this means that we have a responsibility to see if we can come up with remedies to make sure these differences don't arise or are perpetuated. These differences are often associated not with just with people's social determinants, but also with factors in their digital environments. There are a lot of strategies you can consider. Talk to stakeholders about it, look at the literature, but I guess what's central to coming up with a strategy that works is this collaborative process with the stakeholders, not just the patients who use the technology, but also the researchers and other types of people involved in developing and using the tools. Mustafa I think has made a really good case that proactively engaging with the people who are at risk of digital health inequity can create a positive research impact. And this requires a long-term partnership. So it's not a one-off quick thing. It's something that requires investment, and community-based organizations or trusted advocates within communities are a good way to widen participation. And Mustafa has given an example how that can lead to sustained digital health equity efforts among people from ethnic minority backgrounds. I'm going to stop there. I can get, so you feel free to contact us after the seminar if you have any questions, but I think there's a bit of time for questions now. I'll stop sharing my screen.
That's great. Thank you very much, Sabine and Mustafa, for a highly engaging and practical presentation on such an important topic. Yeah, so now I'm really delighted to introduce my colleague Shuai, who is going to give us an update on the Paprika project, which is one of the driver projects for health research from home. Over to you, Shuai.
Thank you, Lee. Let me share my screen. Can you see my screen?
Yep.
Okay, cool, awesome. Hello, everyone. Thank you again for joining our webinar. I'm so excited to give you an update on the Paprika project. For those I haven't had the pleasure of meeting yet, my name is Shuai Shao, the postdoc researcher on this project. I first introduced the Paprika in July, and it's great to see some familiar and new faces here. Today, I will walk you through our latest progress. To set up the stage, especially for those joining us for the first time, let's do a quick recap. Paprika stands for physical activity patterns after knee arthroplasty. It's one of the driver projects under Health Research from Home. In this driver project, our aim is to understand how physical activity changes following knee replacement surgery. Clinically, the goal is to provide insights that can help patients and clinicians make informed decisions before surgery. From a research perspective, we are conducting a retrospective cohort study using existing data from wearables and smartphones, which we are linking with NHS data to gain new insights. This approach gives us a valuable view into post-surgery activity and recovery patterns. Let's go through the workflow. To begin, we work with King's College London to establish a recruitment system to recruit participants who had knee replacement surgery. From those participants, we collect two types of information, identifiable data and activity data. The identifiable data is necessary for matching participants to their surgery records in the National Joint Registry database. Meanwhile, activity data collected from wearable devices and smartphones allows us to track physical activity levels over time and assess recovery patterns. Once the data is collected, the identifiable data is first sent to NGR, where it is used to locate and match participants' surgery records. At the same time, we send a copy excluding the NHS number to the University of Manchester. This copy is to maintain a list for press draws or to notify participants in case where their records cannot be matched in the NGR database, as this would mean they cannot participate in our study. Here at Manchester, we process the activity data to maintain data quality and consistency across different devices. Then we transfer the activity data to NGR to link with surgery data using a unique study ID assigned to each participant. This linkage will allow us to create a comprehensive dataset that supports in-depth analysis. To reach our goal, we have set up a clear plan that keeps us on track and help us make steady progress. First, we successfully submitted our grant application. With the project moving forward, we developed a detailed protocol establishing guidelines on how data will be collected and linked. Next, we obtained ethic approval, a crucial milestone that ensures our study is conducted responsibly. Approval from National Joint Registry followed, granting us access to relevant surgery data essential for linking clinical records with our collected activity data. Here we are at step 5, collaborating with Radarbase, a platform developed by King's College London to design a recruitment system that meets the unique needs for our project. To ensure the requirement aligns with our project goal, we have created a product required document. We call it PRD. This document serves as a centralized guide to define and manage our project requirements. It helps us coordinate effectively with teams at King's College London to design a tailored recruitment landing page that addresses the specific needs of our study. Here is the example how we developed the PRD and collaborated with King's College London to create our recruitment system. After completing the PRD and confirming all system requirements, the next challenge was how do we translate these requirements into an effective web design? Our solution began with the whiteboard. We gathered our team and started designing every page according to our requirements and brainstorming functionalities. This collaborative process on the whiteboard allowed us to visualize the user experience and refine our ideas in real time. But then come with the question, how do we transform this whiteboard sketch into a working prototype? So this is where talent folks at King's College London stepped in. They helped us build a prototype using Figma. For those unfamiliar, Figma is a powerful cloud-based design tool that enables teams to collaborate on creating, testing, and refining design prototypes. It allows us to turn our ideas into interactive models before final development. So here is an example I want to try to show you how our prototype looks like. So this is the initial draft that we have the prototype with the necessary structure and placeholder for each part, and some process about consent form and how we register the account and some task. You can see we have just the placeholder for each task. And this is press draw and feedback. After that, we updated version with the detailed content. So you can see we have the full eligibility check, and we have more information. We have the team members. Once you click join study, we have the refund, the process, and the full document about consent. And there's how register account and more before task, and with more details about each task. And you can see all the devices we want to connect with their beautiful logos. And here is the price draw and feedback form. And also a thank you page after they finish all the tasks. So also thank you for your time today. I hope you enjoyed the updates and got the answers you are looking for. I look forward to seeing you next time so I can bring you more updates on our project. Until then, feel free to reach out if you have any questions or thoughts you would like to share. Our contact will be shared at the end. Thank you. Okay, I will stop here. Send back to you, Lynn.
Thanks, Shuai. We have a couple of minutes if anyone has a quick question that they would like. And actually, I'd like to highlight, because I know you put it on the slide, Shuai, but you didn't specifically mention we had a really great patient public involvement workshop a couple of weeks ago where we ran through the website design with people and invited comments, and we're going to be changing things as a result of that. I don't know if anyone has any questions or anyone else in the team would like to add anything about Paprika. No. Okay, I will go on. That's great. We're zipping through this. Right, I'm going to share again. Right. Yes, so announcements. So I want to tell you a bit about Connect. So we're inviting you all to join us for this unique event to help share the future of health research using smartphones and wearables. So we're going to be bringing together people from academia, industry, patients and the public for this one-day event. We're going to have fab speakers, a co-development workshop, and research and technology showcases, amongst other things on the day. And it's going to be on the 7th of February at the Google headquarters in London. And I can't wait to see inside there, I have to say. So you can find out more and book now using the QR code or via the link in the webinar, which we'll send you out in the follow-up material. And we really hope to see you all there. My next announcement is just to say a little about our next webinar, which will be on the 4th of December at 1 p.m. And we'll be joined by Valenta Hami from GSK and Aidan Aqua, who's a PhD student at the University of Oxford. And they will be talking about developing digital biomarkers to support drug development in both rheumatoid arthritis and Parkinson's disease. And I think Will Dixon is going to be chairing that session. So I think we've had a run through. So the word on the ground that I'm hearing is it's going to be an absolutely fantastic session and really, really interesting and informative. So that we hope that you can make it along to that. And And I just wanted to flag our clinics to help with the challenges of conducting research using patient-generated health data. The Information Governance Clinic will be held every second Wednesday of the month, and it will allow you to book an hour one-to-one meeting with an information governance expert. So you can book via the link provided in the webinar registration confirmation email. We also are going to have technology clinics and patient public involvement clinics, and we're still developing those, but we really hope to share the details of those with you soon. So it just remains for me to say thank you so much for attending our 4th webinar. These are QR codes to the resources. We talked earlier about the resources that are in GitHub. We have a new website, so please come and visit our new website and the LinkedIn. And please, just as you leave, we're going to put up a poll where you can make suggestions for your ideal future webinar topic. And we warmly invite you to be part of our community by accessing the resources that I've highlighted through the QR codes. Yep, and thank you so much, and we hope to see you again next time. Thanks.